to get going. Bob Davis can't be here. He may show up later if he's able. Before we start, let's please just do a quick call to order, and not a call to order, but a rundown of who's here. Please, Justin.
Yeah, we got Matt Ullman.
Here.
Bob Davis is out, we just said. John Ward.
Here.
Erica Libanow.
Here.
Terry Clark.
Here.
Julie Peterson.
Here.
Scott Olander.
Here.
Dr. Kevin Martin.
Here.
Dr. Andrew Thomas.
Here.
Amanda Scott. Michelle Whirl. Nope. Andy Olson.
Here.
Vicky Machoro.
Here.
Edie Utley.
Here.
Rhonda Holden.
Here.
Stacy Olea.
Here.
Jeff Yamada.
Here.
Ron Erlacher.
Here.
Leanne Boulding.
Here.
Okay, she's here.
Got everybody?
Everybody.
All right. Next up is approval of the agenda. I just have two quick changes to make the agenda. First of all, at the top, it's regular meeting, not special meeting. And then the under old business, we're going to talk about the draft agenda for the retreat. I'll add that. Are there any other changes to the agenda?
I move to approve the agenda as amended. I was thinking about maybe we should do.
That's, yeah, that's already up there. I think you got the full version.
Okay, yeah,
That's a good suggestion. Sorry.
I got the old version.
Yep, so that'll be up there. Again, if you have the old version, the safe catch award will be done first in presentation. Any, so I have a motion from John to approve the agenda as amended. Second from Terry. Any further conversation? All those in favor of approving the agenda as amended, please say aye. Aye. Next up is the consent agenda. Hopefully you guys have had a chance to review that. Minutes, approval of checks, the foundation report, the finance committee. Anything that anyone wants to pull from the consent agenda, or any questions or comments about that? No. Okay, then do I have a motion to approve the consent agenda? Motion by Erica, second from John. Any further discussion? All right, all those in favor of the consent agenda, please say aye.
Aye.
Thank you. Next up, we have public comment and announcements. Now, remember, during public comment, if you have a public comment, please keep it to about 3 minutes. Begin by announcing your name and your address. And please keep in mind that during public comments, we do not respond to comments. We'll try to get back to you in at a future date if it warrants it. So is there anyone here who would like to make a public comment? All right, go ahead, please state your name and your address for the record, and then feel free to
Yeah,
make comments.
Michael Barrow, 101 South Chestnut. I'll use this because you don't have a podium for public speakers, which I'd urge you to get. It's a little courtesy.
Okay.
So just a couple comments. I had tried to set up a meeting with one of the commissioners. I wanted to lobby him on different issues, find out where he was coming from on different issues. That was Mr. Clark, Kenny. Terry, I'm sorry. What happened was, well, first, I've been doing lobbying on the federal level, on the state level, both in Congress and Senate and the House, in Olympia, as well as Alaska, for 45 years. What happened to me in my attempt to lobby one of your commissioners has never happened to me before in those 45 years. What happened to me, I tried to set a meeting with a commissioner to lobby him, and I was told I couldn't meet with him privately. Both the director, the CEO had to be there, as well as the chair of this board. Never have had that happen. We have a constitutional right to petition and to lobby, federal and state, and we have it to do it privately. We don't, as I said, I've never had this requirement. So that was, what happened to me was a constitutional violation of my constitutional rights to petition and to lobby. It was pretty unexcusable. And I hope it doesn't happen in the future to anyone else who is trying to lobby this body. Secondly, I just got back, September, I had surgery for my hip at Swedish and then convalesced at Klein Gallen, a great convalescent facility. The work I had done was misdiagnosed for 5 years here, had a great surgeon here. Same guy that is the orthopedic surgeon for the Seattle Mariners. Great guy, did a good job. 5 years I got misdiagnosed. Unexcusable. When I was hitting the folks there at these different facilities, I saw a really good quality of care, craftsmanship, health craftsmanship. And I urged them to come and work here and apply here. The facilities also said they had apprentice programs that they could take people here and train them up there. I would urge that because the difference in quality of care was amazing. I call it quality craftsmanship. Lastly, I would urge you to get some social workers to serve the patients here. You got one social worker, never shows up at the emergency room, I'm told. He's at the operating theater. One of the things that really helps a patient out and the families out is having a social worker there. We should have 2 additional social workers to help them on the finance side and other services. So that's it. I would urge you to get some social workers working here to address, nurses aren't set up for that. Social workers are, had great social workers at Swedish as well as Klein Gallen. And that's a standard I'm expecting here. Thank you for your time. And as I said, I hope what happened to me here doesn't happen to anyone else here in the future. Thank you.
Thank you, Mr. Farrow. Are there any other public comments or announcements? Okay. In that case, then we'll move on to presentations. Our first presentation is the Safe Catch Awards. Now, let me just say something quickly about the Safe Catch Awards because this is very near and dear to my heart as chair of the Quality Improvement Council. Let me just tell you what a Safe Catch Award is, in case you haven't forgotten, but I've forgotten. Safe Catch involves at least one of the following. The catch prevented an event from reaching a patient or staff member. The catch prevented pain, delays in care, unnecessary costs, or workflow inefficiencies. The situation was high risk or had potential for greater patient harm, such as communication errors, surgical site infections, or falls. And the catch led to frontline or just-in-time improvement. So what we have today is we have 2 people here, both of whom are the Safe Catch winners for the 4th quarter in 2022. And we decided, we selected them from among all the worthwhile nominees at our last QI council. I got a chance to talk to them and inform them that they'd been selected and invite them here tonight. So I was really glad to see them both show up and accept this award from us. I told them, and I think you all know it, this is like one of the best parts of my job, right? It's being able to recognize the wonderful work that our employees do. So thank you all for being here to celebrate them. We have 2 winners that I'd like to announce. The first one is our clinical award winner, Aaron Marshall, an imaging technician with Imaging Services. So the reason for nomination was discovering inadequacies in a medical device. She was nominated by Rhonda Holden. Aaron discovered that 22 gauge IVs being utilized for CT with contrast are not adequate to withstand the pressure needed, leading to failure. Failure of these IVs has possibly led to patients having to repeat CT exams. Aaron researched other IVs available specific for CT and has worked to get these new IVs in-house for use. Thank you very much, Aaron, and congratulations. Our second winner here for the non-clinical award is Heidi Rhodes, LPN with Home Health and Hospice. Thank you for coming. Our nominator was April Grant, the clinical manager with Home Health and Hospice, and she was actually nominated twice in this quarter. First one, while Heidi was on At a routine visit, the patient shared that she did not have enough money for food and that her and her husband's income was minimal. Heidi checked to see what time the food bank was open and it closed in 30 minutes. Heidi went to the food bank for the patient and spouse and got them a backseat full of food delivered to them. She returned to the office and got a social work referral, hoping they can have access to other services in the community like Meals on Wheels. So that was the first one. That was good enough. We were impressed enough by that, but there was a second one too. Heidi was in the patient home when there was a loud knock at the door. When she opened the door, an angry woman was screaming in her face and trying to barge through the door. Heidi closed the door and observed the woman getting back into her car and blocking Heidi's car, so she was unable to leave. The woman continued to pace around the front of the home yelling. Heidi called the police and waited for them to arrive. The situation was handled. Patient upset and alone, and Heidi was upset and alone, and Heidi stayed to comfort the patient, even assisting the patient with a shower. Heidi also helped to get the patient a referral for a social worker who was able to come the next day. Thank you very much for the work.
Can I just point out too, you are obviously clinical, but part of the reason you were under the non-clinical category was because some of this is outside of what we were asked to do every day. And was like outside of your clinical scope necessarily. So thank you very much.
We have to make all sorts of strange distinctions doing this work. But anyway, as part of your award, you get a certificate with your name and with the a description of the event or events leading to your getting this award. You get a gift card and a charm to put on your ID badge. So, and your story will be shared throughout the organization, announcements, bulletin boards, and with a banner in your department. Thank you for all the work you do. Now, if you guys have a moment, Terry and I will come out and get some pictures with you and Jeff, we're glad to do that.
All right, so when they get some photos, we're going to carry on with presentations. So we have a process improvement education from Leanne Boulding. Why don't you go ahead and take it from her?
Okay, so I'm gonna share my screen, I hope.
Looks like it's happening.
It's happening.
Is it happening? Can we see it?
Well, it's kind of cut off.
We're,
Oh,
we're getting
there we
there.
go.
Trying something new that my buddy Jeff Yamada taught me. Okay, so sorry, bear with me for one more second here. How's that looking?
Looks good.
We got it.
Okay, so hi everyone. Thanks for having me back. And as promised, I am going to do some brief education on Lean at KVH and our process improvement program. In case there are those of you that may not know me, I am Leanne Boulding, our process improvement coordinator. I'm going to do my best to stick to tack time on this and leaving at about 30 seconds per slide. So we'll see if I accomplish it. So tonight we're going to go through some of the objectives of Lean, which is introduction and history of Lean, some key terms of waste, process walks, improvement methods, and PDCA. So what is Lean? Lean's a journey and not a destination. It's creating a culture of Lean is to create the relentless pursuit of improvement. The Lean philosophy aims to break down management barriers, amplify the workers' voices in designing the work process, cut waste in time and materials, and improve the product. It's really about empowering the team. So Lean is a systematic problem-solving approach. It's process-driven, identifies waste, makes things visual. It's showing our metrics, creating a visual workplace with teams communicating, huddling, and doing Gemba. And it's empowering the frontline staff to identify and solve problems. It's also collecting our customer requirements, linking strategy from the top to the front line. Going out to communicate with staff, identifying barriers and working to remove them, and it drives continuous improvement. You're going to hear continuous improvement throughout every conversation you have with me. So Lean in a nutshell, a Lean management system is really living Kaizen. So Kaizen's a Japanese verbiage for continuous improvement. It's a practice which promotes productivity, humanizes the workplace, eliminates excessive work, and teaches people from all levels of an organization how to thoughtfully spot and eliminate waste in their daily routines. So there's many lean models. You may have heard of Toyota Production System, VMPS, Lean Six Sigma. One of the key things that I do want to point out here is lean is all about eliminating the waste in our processes and truly just about eliminating waste. Six Sigma seeks to reduce variation by decreasing defects to a specific statistical measure. But the concept behind all of them is really they all strive to optimize operations and increase value for our patients. So ultimately, you get the combined hybrid, which is known as Lean Six Sigma. Lean in healthcare. So we could reel all the way back to the 1900s with Henry Ford and the automobile lines, doing the interchangeable parts, the moving assembly line and mass production. And even through the 1940s, World War II, the big shift in our workforce, and then all the way forward to 1998 as it's being brought into healthcare. So lean principles hold the promise of reducing wasted time, money, and energy in healthcare and helping to create a system that is efficient, effective, and truly responsive to the needs of patients. And as you can see from our timeline here, it started in 98 with Children's Hospital, 2002, Virginia Mason, and in 2004, you've got Theta Care and Group Health. And what's super impressive to me, because I wasn't aware until I became an employee in our process improvement department, KVH has been doing it for a really long time. And I'm excited to be a part of this as we continue the journey. So what is waste? So recalling that lean is about removing waste. And so what is it? Is it garbage, barren wasteland, or is it wasting talent and time, squandering our skills and abilities? So waste, according to customers, so value added is any activity that changes the form, fit, or function of a product or service based on our customer requirements. If it's not value added, it's considered waste. So anything that consumes resources but adds no value for our customer is classified as non-value added waste. So think about what our customers, our patients are willing to pay for. So there's 8 wastes in lean. You can think of the word downtime. Downtime is an acronym for the 8 wastes. And those wastes consist of defects, overproduction, waiting, non-utilized talent, transportation, inventory, motion, and extra processing. Some of the examples of waste are in overproducing. So producing too much of something required or before it is required. So think about registering a patient in several areas. It happens all over in healthcare systems, double booked patients. Correction, redoing or reworking, rescheduling our patients, receiving incomplete orders, getting a return mail, inventory, visible, idle, or finished work in process, excess stock. There's even the wasted inventory, which could be hidden and known as tribal knowledge. How many times do people have all this tribal knowledge and potentially walk out the door with it? And what a waste if we haven't captured that. And one I really want to call out is the waiting. Waiting, delays and queues of all types. So waiting for calls, signatures, supplies, equipment, meds, labs, and people. One of our bigger projects, our family medicine project with our phone calls. That was one of the biggest defects we found is our queuing of our phone calls. So that's a great example of what we find in waste with delays and queues. Additional ones are searching, the time spent looking for information, people, supplies, and equipment. We see it a lot, nurses looking for the equipment needed to help care for the patients, people looking for people. Transport, needless movement of people, material, and information. I always call to mind, where's your printer located at compared to where you're sitting in your office? How many steps are you taking? That's transport. Space, storage of unneeded items, excess inventory, or the general mess that builds up over time. And then complexity. Okay, healthcare is full of complex processes. So complex process flows, product choices that confuse our customers, some organizational processes that introduce inefficiencies and frustrate our customers. The referral process is a really good example of getting that referral place from another provider and whatnot. It's really unclear to our patients how that complicated that process can be, and many times very unclear to our own employees that have to manage through that process. So waste comes cleverly disguised as useful work. This is a true spaghetti diagram of a patient and a nurse and a patient waiting for a clean bed. And all of those lines, that's the movement. And that work had to be done in order for that patient to get placed. So again, cleverly disguised as useful work. There's a lot of chaos going on in here. It took a total of 52 minutes for this environmental services staff to clean the room. So there's a lot of waste to transport in there. This happens pretty frequently. And so truly what we're doing, waste is a burden we are putting on our employees and patients. So waste is not the person. If you've been in a room with me before, I call that out continually. Waste is not in our people. It's not in the person. The waste is in our processes. And so when we can get to a level of where we can create standard work, which is the effective choreograph of people, information, supplies, and equipment into reliable processes that deliver consistent quality in a timely and safe manner at a less cost, you ultimately will end up with a satisfied customer is the goal. And then having standard accountability, sorry, I'm a little nervous. Having standard accountability, having the systems in place to show where the problems live will provide the balance for the processes. And problems in a lean world are gold. They truly are. It's where that's where my passion is. Let's find the problems. And then having the daily accountability exposes and facilitates solving the problems. And how do we find the gold? The gold, we go out on Gemba and on process walks, truly going to the place where the work is being completed and observing the work with the people who do the work. We need to hear their voices. They're the ones that are going to be the best to redesign our processes. And I just love this picture here. That is truly big eyes, big ears, and little mouth. And also seeking to understand, be curious, go out on Gemba, seeking to understand, listening to our employees and understanding where the barriers are. And while we're out on Gemba, and not actually at all times, it's all about respect. So everything we do, going out on Gemba, all aspects of improvement really is to keep respect for people at the top of mind. I won't go through all of these, but it's one of my favorite. I think it should be and can be applied in any organization anywhere. And then through improvement methods, I'm going to share a few of the methods we utilize in process improvement. So again, Kaizen's a Japanese term to continually improve. So we've got our A3 thinking, looking at what's our problem, what's our root cause, and doing RCA, and then prioritizing the causes. And then using our metric boards or visual boards, those can really help bring out the problems. If your board has a lot of red and it's not supposed to have red, then there's your opportunity to begin improvement. How do we do this? You can do quick improvement with your team at a huddle board, utilizing the A3 thinking, and then 5 ways to think about improving our work. So can we eliminate steps? Can steps or processes be eliminated? Can we combine steps or processes be consolidated? Resequencing, can you change the sequence of steps or processes? And then a new tool, can the work method be changed? Or going as, can we make it simple? Can you simplify the steps or processes? So think about the spaghetti diagram. Can we remove some of the steps in that process? And that would help simplify things. And just to make it clear, that spaghetti diagram was done for many years ago. I don't know what it looks like today, but just so that we don't walk out thinking that's how it happens currently. And then 5S. So I'm not going to try to pronounce these in Japanese because I would butcher it, but 5S is actually a strategy that helps to keep our workplace safe and organized. And it's really where all improvement activities should start. Help you get rid of the low-hanging fruit. So the 5 S's are sort, which is proper arrangement, simplify, meaning arrange for immediate use, sweep, cleaning it, keeping it clean, standardize it, and then self-discipline, continually keeping it in place and organized. That is the hardest one to sustain, is self-discipline. And then we have setup reduction as another method. Setup reduction is the time spent preparing to provide the next product or service. And setup reduction is a method to reduce or eliminate setup time to increase capacity and flexibility. I love setup reduction. I use it in my own life. I've got my coffee pot with a timer, saves me a few minutes in the morning so I can get out the door quicker. And so there's all kinds of modes of utilizing setup reduction. But when you think of typical setup activities, mostly anything ending in INGs, like gathering, transporting, opening. I do see the word presenting on here, and I think I need to remove that one. And then we've got disassembling and cleaning. So setup reduction will and should help increase capacity, productivity, quality, flexibility, on-time delivery, and then value-added time. It will and should decrease your bottlenecks, space requirements, need for large batches, waiting, huge on that one, lead time, need for adjustments, and then downtime of staff and equipment. And then one of the other tools, I believe many of you have seen this at the last presentation in February, but this is an idea form. This is I like to utilize this tool when we can't get an entire team in the room. This is a way for the entire home team to have their voices heard, their ideas heard, and they literally write out what's the area of the problem, proposed changes, what are your ideas, how would we go about it, and what type of results would come from it if we can implement and act on some of these ideas. Very useful tool. We have seen some really great outcomes by utilizing this and have acted on many of the ideas. And then from improvement in an event and moving forward into the home team, any improvement, PDCA, plan, do, check, act. And it's basically you're planning, you're determining the goals and targets, determine how we're going to get there, the methods, you educate it, the methods and whatnot, and you implement the work. And then you continually check the results and you take the appropriate action. You either act or adjust. And so when you're looking at acting and adjusting, if you can standardize the process, if results are good and has been tested, return to planning if results are not good. Not always do we walk out and we're going to PDCA something. We can find through that testing, this isn't working well, let's readjust, let's go back to the room and whatnot. And then when it's successful, you share the success and expand it. A lot of times we can take this improvement work that we're doing in one area and expand it organizational wide. So that's the gold in that. But also be careful not to get stuck in the plan and never do. Whenever we do an event, when we get to the PDCA, and I will say, I believe every time we've walked out of the room on all of our projects, we have action items. We're going to trial something out. We don't want to walk out of the room without having a few action items to trial out, and it's showing improvements in many areas. And so once you're done with your PDCA or essay, as others may know it by, you document the new standard, you create the implementation plan, then you train the whole team, and then you implement. And then you continue to monitor and adjust as necessary, because as what you find, it's continuous improvement. That is what we're experiencing on every one of these projects. It either goes onto a parking lot or it's actually in scope, and we continue to improve upon the improvements we're working on. So there is our education. I did want to share a real quick update about the process improvement program as we continue to improve. As of today, we've had 15 leaders come through our Lean for Leaders cohort. I must say I'm extremely excited about that. And we are beginning cohort 3 in April, and we are going to start doing mini sessions of education to where staff can sign up and come in for an hour-and-a-half session with me on specific topics. So I could sit here and talk with all of you for hours on end about process improvement, tools, methods, everything. I'm very, very passionate about it. And I'm just really excited to be a part of continuing the journey of process improvement with KVH. So thanks for having me back.
Thank you.
Can I just, Leanne, can you tell us how many projects you're currently on and how many you have waiting, pounding on your door?
I can. So currently I have 11 active projects. I actually was able to kind of tie up one of them. I have 11 active projects currently. We have 32 potentials in queue. And along with that, we continue to, I continue to work on developing the process improvement program. And then through our leader education, I have leaders writing down so many projects that were coming to mind, because now we've got some tools and we were getting some familiarity about the process and whatnot. So there's excitement building. So I believe we're going to see a lot of projects going on for years to come. I mean, that's what it's all about, continuous improvement.
Thank you, Leanne. So do we have any other questions or comments? Leanne?
A great presentation. I like how it was laid out and easy for me to understand that somebody who's not intimate with the lean process. So thank you for that.
You're
And I
welcome.
I know did a couple of the commissioners go and Gamba at the actual process meeting that they did for family medicine? I thought we were trying to set that up.
I think John and Terry, you attended that process improvement
For the
meeting, right? Yeah.
Oh, yeah.
Yeah.
Oh, yeah. Yeah, that's, yeah, fascinating. Just a lot of figuring out what the problem is and just step by step, how do we tackle it? How do we improve it? So yeah, it's exciting to see all of the thought and effort going into, improving that really important customer service front end piece that people, that's how they kind of see the hospital at first. They try to call in and if they can't get through and get frustrated. It's not a good start. So.
I just want to add to, I know she was really trying to keep this brief, but like the idea form that was on there, she has a whole toolbox full of ways that she's getting improvement activities and engagement with the team. And we really have to use Leanne's expertise when she's facilitating to decide what's the right tool for this group and this improvement activity. And that's where I think this is a really great resource for our leaders too, who don't have these years and years in background and experience with all these different facilitation styles and brainstorming tools. So we're really fortunate to have her and her experience from other organizations that also had these different process improvement tools.
Couple of things that I thought were particularly important that you mentioned. One thing you said you repeat all the time, and that is that you're trying to improve processes and people are not waste. And so we're not trying to sort of eliminate people. The other thing when you were talking about Gembas, I thought, I mean, I don't know a whole lot about lean. I know more now, thank you. But the one thing that I always had heard about it was that it's, you're talking to the people on the ground who are actually doing the processes to get their insight into how they can be improved. It's not like a top-down imposition, it's actually a bottom-up process. Could you say just another word or two about that piece of it?
Yeah, absolutely. So it truly is exactly what you said. It's about empowering the people. So to touch on a couple points there, lean is not about the person, or people are not a waste. And you will hear me say this over and over, because unfortunately in many organizations, when lean was implemented, it was potentially used as a tool in the wrong aspect and kind of used as a weapon towards people. And that's not what it's about. It's about process improvement and improving the processes we ask our staff to maneuver through. That's the importance of going on the Gamba to talk to the people. They're the ones functioning in the process itself. They're going to have a better idea on the design of a process and making it more efficient than, let's say, somebody who doesn't ever have their hands on it. Or okay, as leaders, are we entrenched in the process of scheduling a referral? Probably not. We probably don't know the ins and outs of it. So who's best to make the decision on what could work better, or at least getting those ideas so that we can trial it and implement it. So it really is all about empowering the people. And like you said, it's not top down. It needs to be coming from the bottom up when we're improving our processes.
The other piece, Jeff, the other piece of lean Toyota production system is empowering the employees. So basically, and Leon can talk about it, anybody can stop the line, right? So if somebody sees something that is not correct, everybody is empowered to stop that line.
Yes. When we go out to do our PDCA, three major rules: stop the line immediately, and then we alert the team, our executive sponsors, and we go back to the room is when it's patient safety and harm first and foremost. And then if there's it's creating non-compliance with our regulatory bodies or illegal activities, stop the line immediately. We go back to the room, start over and do the drawing, back to the drawing board on it, and continue to improve that. So that's a big empowerment when your staff can say, we can't do it this way and we've got to stop now. That is very respectful. And just going and being on Gemba with staff, how respectful is that when they get to share how they maneuver through their day and the processes, and here's an idea on maybe it could work better this way. So I think that's pure respect.
Thank you, Leah.
I have a question for you, and this is Erica. As a commissioner, what can I do to prepare myself to engage most effectively out of respect for the process and for employees? I am lean naive. I don't know a whole lot about the process, and I can't imagine that I can just step into the role of a Gemba and get the most out of it without any sort of an education about it. What kind of suggestions do you have for me to be able to enrich that experience?
So to go out on the Gemba and whatnot, number one, I would always announce that you're going to come and do Gemba in a department's area and whatnot. It's a little intimidating if somebody just walks in and you're starting to observe. That can be very intimidating to staff. So if respectful, let them know you're coming. Ask, inquire, be curious with them. People want to share, and people do actually like to be asked about their work and what you do all day. And a big one to kind of get them to open up about maybe some of the barriers. What are the rocks in your shoes? And be prepared to have that feedback from them. Be open, honest, candid, transparent, follow through on anything that maybe you say, well, we'll take a look at this. Make sure we follow up on our promises like that. But really, just to be prepared, you don't have to know the process, but to be able to have that conversation with the staff member working through that process. Ask them, what's the most difficult part? And what are the great things you love about this process in your job?
Thank you.
Thank you, Leah. Any other questions or comments? Thank you very much.
Can I just say one maybe don't do? Suggesting what they could do instead is usually like one of the easiest things to, like, you could just don't try to offer suggestions. That's like the easy way that you can offend employees. Is
Are you
just
talking
like
about the board specifically?
anybody, like
Anybody.
going on again, but to the process walk is like, if you start saying, well, why don't you do it this way? Or have you thought about this? Or that is the quickest way to have it turn into a not very good interaction.
Yeah, we call it solution jumping too. So thank you, Mandy. But yeah, absolutely.
There's a quote that I love that I have on all my Gemba documents, and it's go see, ask why, show respect. So the most important thing I think is showing respect for the individual and the work they do.
Thank you. All right, thank you very much, Leah.
Thank you. I'm happy to spend hours on end discussing it with you at another time.
All right, open door. if anybody wants to.
You're over time.
Thank you very much, Leah.
Thank you.
All right, next up on the agenda, we have Ron Urlacher with a construction update.
Yeah, so we're just getting ready to get this thing kicked off, and a few things are starting to happen, so I'll come here each month and, update, so. There's things that if you'd like to see that I haven't included, just let me know and we can address that. First thing I wanted to go through is just some of the maybe challenges along the way and kind of what we're facing at that moment in time. So we'll start with that. And the first thing is the fire main that came into the old 2,000 addition, there's a surgery wing, and then it takes care of all of surgery, ED, and up here. That crosses the excavation area, so there's no way to support that pipe while they're digging the tunnels and foundations and all of that. So we're having to find a different route for that.
Hey, Ron, so this is a discovery since we started this process. They discovered this was an issue.
Yes.
Okay.
Yeah.
So just, sorry, for the board, separate from your packet side here, there was, I think that's what you're going through here, Ron. So the
Yes.
current challenge is he's talking about now, and then I just want to make sure that.
Yeah, I think in the future it'll be part of the agenda, but I got. So,
Sorry, Ron, go ahead.
no worries. Yeah, so, yeah, the contractor's just saying there is no way to support this type of pipe underneath it. It's meant to be buried in the ground and supported by the. And so rerouting it seems to be the best way to do it. And there's, the fire marshal was adamant that in no way are we going to go without a fire main for that period of time.
And the fire main, does that like contain water or what?
Yep, it's all these sprinklers.
Just put out fire, it's not creating fire.
So they're virtually in every room, fully sprinkled facility, so every closet, everywhere there's this. So what the plan is, like now, is we will, you can go through that.
Is that the other one? See, I guessed wrong.
I walked up the back of the hospital this morning and there were 4 guys in hard hats staring in the hole and I thought,
Never a good sign.
This one right on.
Yeah.
Okay.
So near the top of that map, you see that. Well, actually, where the parking is on the north side, you see the green block there. Yeah. So just below that is where we'll enter with the new fire main. And that's the existing building. And so it'll come into the basement there. And so the fire main originates from the other side of that emergency traffic only lane, red, yeah. Just to the right of our shop building there is where that main is. And so it'll be extended on out and then come into the basement. And that the pipe size in the basement is already large enough to carry the entire flow because it was a loop system. So that's a good thing. Once they're inside, they don't have to go very far to connect back up to the system. So it looks like that's our best choice at this point. We looked at temporary lines and there was lots of challenges with that. And it also meant rework. And so we felt in the end, just a permanent line out of the way would be the best. So that's what we're planning on that.
We have an estimate of delayed, amount of time that this adds,
No,
days,
Well-
weeks, months.
days, if anything, yeah. They're excavating there anyhow. So below it, like in between internal medicine there and the new building addition, there's a water retention pond that's underneath the driveway there. And so they've got to excavate all that anyhow. So there's.
Are they gonna temporarily use up some more parking spaces that we were not planning for also?
Nope, those are all gonna be out of the use anyhow. Yeah. So if you look, see that dotted red line, yeah, that's basically where their construction fencing is gonna be. So they will encase that whole thing. They'll be having big equipment move back and forth and big holes in the ground. So they will take all of that. So while I'm here, I guess we'll go ahead and just finish up with that part. So next week, we will have, we're replacing the fans and the air handler that serves ED, and that was part of the energy project. And so that will be happening in that lower right corner where it's kind of orangey yellow color. They'll be moving the equipment from that, the parking lot over to the building, and where it says lift zone there is where they'll be lifting up the new equipment onto the roof. And so that starts off Monday. So that's a week-long process to convert that air handler to the new fans. And then the following week, construction has that area will be up and running. So they're doing some preliminary work that you might have seen out there, but on 4/3, they'll start that off. So right now, because our helipad is on the roof right next to that air handler, we're using an alternate landing zone, and it's by the fire department. And the fire department is doing all the transports from there to the hospital. So we worked all that out ahead of time. So that's in effect as we speak and until the end of next week. Kind of the gist of that. So yeah, the blue dotted lines there is the ambulance. Well, it's traffic flow, but the ambulance will come in off of Manitoba and then into the ambulance bay where the red arrows are. So that will be their pathway for the duration of this project. That temporary lane is already cut in and ready to go. So they can start using it now, but as of Monday, they'll have to use that. That's all been reviewed with the city and fire department and ambulance companies. And yeah, so we've been encouraging folks to find some alternate parking, walk, whatever, because it is going to be tight. We do have that new north lot that people can park in, so that'll help. But it'll be tight. All right. Any questions on that?
We knew the water table might be a challenge, so there's no new information on what level of challenge it's gonna be.
A little bit of information, yeah. So they dug a test pit today, and it's kind of out back where the MRI building was, and they were down to 11 feet before they hit water. And yeah, so we know where the water table's at in the area where we're digging, but what we don't know is because they'll have to go below that, how much water is going to flow into it. And that's the big variable is what's that flow? How much do you have to get rid of? We know it's going to be there, but
That level changes depending on time of year.
it sure does, yeah. Once irrigation gets going, it tends to come up, and then it has to do with how fast the snowpack melts. And yeah, those are both big factors.
If it has to be pumped out, where does it go?
Pardon?
If it must be pumped out of the excavation site, where do we displace
They're
it?
gonna build a retention pond in the grass area near the creek.
Okay,
And then we have dry wells on the property that take the storm water now.
okay.
And so they will filter the water that they're pumping and then put it into the dry well.
Okay. It's nice that we have a place for it.
Yeah, and, if you can't keep up with it that way, then, you're looking at watering trucks that they fill up and drive it outside.
Oh, boy.
Yeah, we want to avoid that, so. Yeah, so hopefully, the flows are not so great that we have to do that.
So cross our fingers for a nice cold snap for a while.
Yeah.
All right.
So monthly for Ron, an update, sometimes virtual, sometimes they'll be big, and sometimes they'll be there, so. Is that going on?
Sounds good. Do you want to add them to the reports? Or should we stay in?
Do you want to go in operations or do you want to go in after Scott maybe, or?
I like it in presentations and update everybody and then move on.
All right, we can leave it there.
maybe that?
Anything else?
Yeah, the next sheet.
I knew what the answer.
And it won't mean a whole lot now because we're just getting started, but got a project cost dashboard. And so it compares what the construction cost was, what all our equipment added up to, and the contingencies that we added to those numbers is the bottom bar of chart. Then as things go along, then the top number will be adjusted compared to what we had budgeted. And so, yeah, so right now we're at 26 million. And so that's the number with all the small works contracts that I got in place, the construction contract that we have in place, what equipment has been ordered, and so we have actual costs for those. And so probably the biggest variable there will be change orders in the construction process and actual costs for the equipment. So Oregon and now Bonnie have got a really good jump on that. So I really don't anticipate seeing any big changes in the equipment. In fact, it's gone down some, which I think we're able to eliminate because of the misunderstanding. They thought we were providing that. It's actually in the construction documents. The contractor provides, so some of that out and make those corrections. So anyhow, we'll see if things go along.
So the project cost is all contracts we currently have in place, ready to be executed. So we haven't paid them, but we have
Yes.
obligations that
Exactly.
accounted for.
And then the bottom chart, we're just starting, so there's, we're on schedule. We'll see how that goes. So a bar on the bottom will be very ahead of schedule, and a bar on the top will be behind schedule in days. So we'll keep track.
When you approve the project,
We
as the board, we were issuing purchase orders the next day to lock in the equipment prices.
Some of those were,
Because they
they
were,
were, they're on trending up.
so they were trending up. So those, there were a whole host of purchase orders that were issued with a lot to lock in pricing. So that was.
And a lot of the vendors have been really good about getting that order and holding it for us, which is really nice because then you can say, hey, ship it now and be just in time.
Any concerns about any of the building materials? I know there was, when we were negotiating the contract, there were just some unknowns as to the availabilities and the stuff. Is there any concerns now that we're a little farther underway?
Nothing big. We've made some changes in the aluminum products for the windows and doors and things like that to a different vendor. And yeah, but nothing that the air handler new part is a pretty long lead item, so probably the worst of it that I know of. I think that'll still be on time. So then also submitted in it, will just be, for right now, it doesn't mean a whole lot, but it's basically all of the owner equipment. And so next time we'll print it in color because the bars, different colors mean it's on time or behind. And that becomes significant when you go from phase to phase. So you want to be able to keep the contractors going, from phase 1 to phase 2. If you hold them up, then it extends the timeline. So we want to make sure we have all our equipment here. If there's parts of that are needed for pre-install, we've got that on time. So it's our way of tracking that. So far, so good. And then that's our phasing plan up there to kind of give you an idea of how we're tackling this. So phase 1 will build the additions all the way around, and it will finish all of those spaces. And so in phase one, we will have imaging up and running. And so that's approximately 9 months is what we're looking at for that. And so once phase one is built and tied into the building, then we'll be looking through the walls and into phase two. And so virtually all the walls around the existing perimeter come out and get expanded into the new area. So that will be, there'll be lots of little sub phases to pull that off. Go ahead and go to the next slide. That's just upstairs on the helipad landings, a little bit of work that we have up there. It's phase one. And then this one shows all the, after we do phase one, it's a bunch of shuffling around of different rooms to temporary locations, moving equipment in prep for starting phase two. So this follows directly behind phase one. And then phase two will, it will tackle the old central sterile. They'll be in their new space. So that'll be just kind of a turnkey process, getting them in there. And so they'll, you know, they shouldn't have any delay in being able to keep operations going. And then their old space will then get converted into an endoscopy processing room. And so it will take in that and it will make the modifications in materials management, get that wall broken through into the new area. And then it will also include adding the extra bay in the recovery space. And yeah, that's the gist of that. There's some finish work in the endoscopy rooms that will also include. So those are just kind of the sub phases of that. We can go through that. And then, you know, these are the moves that have to happen to prepare ourselves for phase three. And so we went over this plan with all the stakeholders and made sure that, you know, we weren't pinching them too much to stay operational, to keep us going, and we kind of adjusted the lines and how we were doing it based off of that. I think we've got a pretty good base now to work from. And yeah, phase three is just some finishes, and then, yeah, in the pink area there, that one will be pretty short. And then phase four will redo all the finishes in ORs 1, 2, and 3. OR 4 is phase one, so they'll have that one in operation. Then we'll go into OR 3, take it down, and do everything in there, and so on down the line. And then all those corridors get updated finishes along with the nurse station, and the women's locker room gets expanded. And so all that's in blue is after hours work, so that they stay operational during the day. And they're in this phase. By now they'll have the new penthouse on the roof that houses all the equipment for the ORs. And so that work below that penthouse will all happen while this is going on. So we'll have 2 separate contractors in here doing that. That's about it.
Questions?
Anything else that you'd want to get reported on?
No, I don't think so.
I think we're all set.
Thank you.
Thank you. Okay. So now on to reports and dashboards. First up, quality manual.
Should we talk about
asking first? I'm asking.
Why do you do your regular report?
Okay. Let's do that then. So, just some information about updated guidance to surveyors. The reason I want to make sure this was in the report to you is that there's a certain amount that our commissioners are supposed to understand about what's happening with quality. And I think you're all very involved in quality and do understand this, but I just want to make sure you knew how we demonstrate that when they survey, so that you were aware of the types of activities that we would be sharing with them that meet the conditions of participation.
I think we all got an email to this effect, right?
Yeah, Julie sent it out from AHA, so.
Hopefully you guys were able to.
And there's a ton of red writing in that, and it's actually one of the more helpful documents from CMS because it's what they give to all the states who do the surveying for them to the conditions of participation. So in Washington State, CMS doesn't come out from CMS to do our surveys. They contract with Department of Health, who those inspectors come and do our CMS conditions of participation survey. And so they have to create a manual for those surveyors so they know how to survey consistently across the whole United States. So this was update to that guidance to surveyors, which is actually really helpful because it tells us exactly what the surveyors should be doing. What was a little interesting about this updated guidance too is it was very clear that you should not give the hospital a finding based solely on something you see in their data that we're required to look at, right? Or a previous incident that you're looking at. So it had to be something the surveyors observed while they're there. And I thought that was really interesting. I don't remember that being in there that explicitly in the past. And I don't know if it's because they had some surveyors that were basically punishing folks for the improvement work they were doing when they were finding opportunities and then working on that. So that was interesting. And if anybody had any questions about that, I'd love to.
When I looked at that thing, I got the impression that we were, the board anyway, you were, let me put it this way, you were involving the board was involved as we needed to be. Did you see anything there that I missed that we're not doing that we need to do?
No, and I thought it was interesting that they said it's the third most common finding, and we really haven't had findings related to that. So I feel like we have a very robust quality program, and I don't necessarily have concerns. There's always places we could improve. And so one of the places Julie and I are looking at right now, and actually Tricia will be helping with a little bit, is evaluating our contracted services. In the past, it had been interpreted that you only had to look at your patient care services, but it's that you actually have to look at all your contracted services at least annually, unless you have a way of hearing those contracts to focus on the highest risk or kind of most important for patient care. So we're just working on improving that process. We already do this, but how could we make it even more robust and make sure we're not ever missing anything?
As far as board involvement, is there anything that we need to do differently? It seemed like you were involving us.
I think you're very engaged in quality. And no, I think
Good, I was looking for a
I
comment.
really appreciate it.
I was fishing for it.
Got it.
Thank you.
Thanks a lot.
But yeah, I thought it was, I mean, I appreciate how much you from the board keep us involved, especially with that coffee process. So when I said, when I looked through that, I was heartened to see that you get us involved. It seems as much as we're supposed to be.
Well, and you did bring up, so at the most recent survey we had with DOH surveyors, she made comments that our board wasn't aware of our metrics and improvement activities happening because they weren't specifically called out in the minutes. I feel like this guidance actually spelled that out more clearly, that it doesn't have to just be in the minutes. That there's all kinds of materials and ways that the information is shared with the board, with staff. So I think that was maybe also, again, another clarification surveyors, not necessarily the hospitals, about what that might look like. And I remember that was a big frustration on our part, like, oh my gosh, we're providing all this information, we're having all this dialogue, but just because the exact words we said weren't in the minutes, like, you know, that's not what makes our robust program. So I think you do an excellent job.
Okay.
We have a new dashboard, so I don't know if you had a chance to look at it, but I'm really excited. It did extend into 3 pages just because of how we have grouped things now. I didn't know if you wanted me to go over the changes, or if you had any questions, or.
I don't know if you guys remember, but we were presented with a list that showed what was gonna be dropped, what was gonna be added. I'll just ask, hopefully you guys have had a chance to review this prior to the meeting. You guys have any questions about any of the changes?
Are there any changes that you wanted to call out specifically for any reason, maybe?
One I think we should definitely mention is the sepsis bundle, which is on, I think, page 3. Yeah. Page 2? Oh, yeah, hospital metrics, okay. So you may or may not recall that the previous goal was 100%, and it's changed to 80%. And that's not because we're like, we should not meet this measure 100% of the time, but actually the state average and the national average is about 67%, 57 to 67%. And so we're trying to set a target that is more realistic at this point in time, and, you know, in comparison to benchmarks. So that is still a top priority to get to 100%, but it was changed. Also on this page, you can see we added the suicide risk assessment and intervention bundle. And that graph is just so pretty to me. So DMV came in June, and we had our follow-up survey in August, and they were so impressed. And this just really shows all the work that was done by our nursing staff, and actually our informatics and staff development, and Bonnie, our QIRN, and Cody. So they really worked hard, Jeff Holdeman to improve this process, and you can really see it. Let's see, what else? There's there are certain things that were removed, like the sepsis antibiotic timing. I know you know this, but it doesn't mean we're not measuring it or looking at it. It just means it's not on this dashboard. There's still work happening every day on those, and they're being reviewed. On the 3rd page, the blank spot on page 2 is for mortality. It really is not super helpful on a month-to-month dashboard, but it's pretty much a standard that is supposed to be looked at and considered for oversight. So we're gonna put it on here. It's being reported like to RPG. It's something we look at, but we just felt like it would be good to have on here again.
Sorry, what did you say, the blank?
Mortality. And it's hospital mortality specifically. It does not include the ED. So on the 3rd page, that we changed the hospital for infections to be split out between specifically surgical site infections, and then any that are above, like you can see in July, there were 0 surgical site infections and 3 others. So that could be like catheter-acquired urinary tract infection. If you can't see the blue dot, it's because it's behind the red one. And then the same is true with it used to be called needle sticks. And we changed this to potential bloodborne pathogen exposures. So this also includes flashes now, and other instances that don't involve needle sticks or sharps. I think that's, we have on the first page, sorry, I should have, the changes were in the order they were on the old dashboard, so they're not in the order they are on the new dashboard. I know it's about it. On the first page, we're putting clinics first. And that's often how people enter our system, and we're really excited that the fall risk screening is on there and the diabetic quick checks. I'm so happy to see these, like, it doesn't have the standard deviations on there, but you can see that there's change happening and real improvement, and it's really exciting. Look at FMC there, like Dr. Thomas has done some really great work with his teams. Yeah, should be proud. We're trying to spread that to others. But those are measures that we previously could not even see how we were doing in the past. Cerner has a module that includes data that you can report to CMS as part of their quality performance or QPP program. But we're specifically told not to use it because it's for improvement work. It's only for reporting. You can't change the date. The date, you can't manipulate anything in the report to help you see things better. So this data collection itself took a really long time to sort out. It took Amy Diaz and Dr. Hibbs working for a long time about how to pull the patients out correctly to get the right population of patients. And then we had a whole lot he was doing on the back side, then making sure that any patient that should be excluded wasn't in the data. And so that took a year to get the data this way and then to be able to look at it. And they've been working on, you can see, how we improve it now. And we can see some of it. And so Tony Clayton's been taking the data up to the individual clinics. I think she's been going monthly and sharing this with staff and making sure they know how they're doing. Recently, we a product that a company we've been working with, Adaptics, after 2 years or plus of work with them, we're live with their product, which is a tool where we can look at quality indicators and sort it, do all kinds of things with it within that application. And just this week, we did some validation with Dr. Hibbs and Amy said she actually thinks their data is better than this data, and Dr. Hibbs said we could start using it. So that's like, and those two say like they're comfortable with the data. So that's really exciting because it gets updated every 24 hours with certain data. This is the first time I know of, and Jeff could speak up to this. He's part of how this even happened. Was Cerner, we're a beta site with them where they are actually just turning on the data tables, like letting them flow to us. In the past, they have never allowed us access to the data tables or even how the data is mapped. And with this partnership with Adaptics, the data tables are flowing to Adaptics. Adaptics creating an extract that goes into this application, and then we can look at the data. It's pretty. So it may be that in the future, it's the same data here, but it might come from Adaptics instead of all this manipulation happening by people. I think that's all I have about the dashboard. Can you share questions?
I've got a question on your summary of improvement opportunities.
Yes.
Bullet points, your first one. I just need a little clarity so I understand what it's saying. There were 7 patients with sepsis in January. 5 of those patients met all the components of the bundle. And then the next sentence, in both instances, there was a gap. What's the both instances you're referring to?
So the 2 remaining.
Is it, yes, it's 2 that are missing from the
Yeah.
5? Okay. Or I mean, from the 7?
Yes, there were
7?
the
patients
2
with sepsis?
patients that did not meet the measure, the 2 of the 7. So 5 met the measure, 2 didn't, out of the total of 7 patients. It was a delay in the lactate lab order that caused them to fail.
And what causes that? What causes that delay? Any sense of that or?
Well, we have, usually what the problem has been in the past is not the first lactic acid, it's the second one. And so we have this new auto order working where the second lactic acid will be ordered. But in both of these, they didn't order it in the first place. And so sometimes that happens because they're not suspecting sepsis right away and they're thinking something else. Or they thought sepsis and usually that's my understanding of where this measure starts is when as soon as you identify sepsis as one of the as an issue, that's when the lactic acid needs to be ordered. And I think in these cases, they just didn't order it for whatever reason. So feedback's given to the care team in any of these failures, and so that they can look at what happened and give us ideas about where to improve. Or if we see that it's, like if this keeps happening, then we go and look at, okay, what's the trigger for,
The lean process.
yeah.
I'm going to find out what's causing this.
So some of the people that went through the Lead for Leaders training was Bonnie, who is my quality improvement RN, and Cody, who's our sepsis and stroke and trauma coordinator.
So, because I was just curious, since we were doing some discussions on some new lab equipment, I wasn't sure if it was a failure of our lab equipment,
No,
but it just,
it's a failure to order.
okay.
And if memory serves, that it's time from the door to draw. So if sepsis isn't suspected immediately, the order is delayed, draw is delayed.
Yeah.
I don't know for sure. I can't remember. It's a bundle, so there's a whole bunch of them, and some of them have to do with, like stroke is from when they get in the hospital, where I think sepsis is from when they suspect sepsis.
Okay.
But
Then corrected.
yeah,
Thank you for the clarification.
Any other questions before we get to the discussion of that? Anything else we need to know before we talk about next? Okay, so you wanted to talk briefly about
yes.
masking requirements.
Yes. So, as you may or may not know, I would think you would. People are asking about it a lot. The Secretary of Health order related to masking in all of healthcare for source control is ending on April 3rd. This came out, 20 days ago or so, a few weeks ago. And between Julie and Drs. Martin and Larson and different infection preventionists at KVH, but colleagues at other facilities and other agencies, we've been trying to figure out, what does this mean, right? What's happening now? We've been dealing with 3 years of changes and guidance and regulation, but it's a little tricky now to figure out how do we go best? What does it mean? What process should we go through? So, the first thing I want to mention is that masks will never completely go away. We're like, are masks going away? No, they're not ever going to go away in healthcare. They've always been a part of what we do. They're a really important part, just one piece, not the whole, but a part of infection prevention. You've seen images back hundreds of years, even when physicians were wearing masks, well before even modern medicine. So masks are going to be a part of how we make sure that people don't get sick inside our walls ongoing. And they were part of PPE, and they still will be part of PPE when we have standard or transmission-based precautions. They were voluntarily worn by staff previously too, when they were not feeling best, but felt like they could still work. I remember incident reports prior to 2019 where people are saying, can you make this person wear a mask? They're coming to work and they're coughing. Can we please make sure they put a mask on? This was well before COVID. So that will continue, right? That people wear masks when they're feeling symptomatic, but not feeling poor enough that they should stay home. So with the order ending, it's kind of, now, well, we go back to what we've always done, which is following the rest of the regulations or guidance from all the different agencies, CMS, DOH, LNI, OSHA, CDC. There's laws about infection control in hospitals. And I wish I could tell you that it was really clear and really straightforward and super simple, and they all align, but they don't. They are conflicting at times. And in fact, even the LNI website right now contradicts itself a little bit. It's not consistent on its own site. Related to that, we did hear today, just today, a week and a half before this goes into effect, that we're working on revising that, and it'll change. But it's still, they're still getting ready for this change themselves, even some of these agencies. So we have always followed guidelines and requirements, and we'll continue to do that as we have before COVID. So this is for discussion Julie and I have had, what we are best thinking right now with the information we have in this moment, which could change.
I think that's enough disclaimers.
Yeah. Well, so we were gonna follow DOH guidance. What we have right now, DOH guidance is that they continue to recommend masking for all people in all KVH facilities, especially in patient care. So that's universal source control. So we will recommend that everyone in all settings, especially patient care, wear masks. CDC guidance says that it is only required in certain situations. When there's a known infectious disease, like someone comes in and they know they have COVID, or you know you have the flu. We know we have a tuberculosis patient or meningitis patient. If you have symptoms of any of these diseases, like you go in the clinic because you have, vomiting and diarrhea, you should put a mask on. If you go to the clinic because you're coughing, or you should wear a mask when you go into the clinic. Or you've been exposed to COVID. So this is the one piece that is different than prior to, we didn't always have masking requirements for folks who are exposed to infectious disease. There were some related to whooping cough at one point and influenza, but they were very special circumstances. Well, now that is the case whenever an employee or a patient or a visitor is exposed to COVID, they'll need to mask when they're in our facilities too. So this is coming up really quickly. April 3rd is week after next. And this, like I said, is what we're thinking. We will follow the recommendations and we'll follow the requirements. There is signage to be changed. There's policies and procedures to be changed. This is the first time we've talked about it, like outside of discussions. So we're going to have to do a lot of messaging. It's universal source control has been really easy in that you just wear a mask all the time. As we transition back to more standard precautions, transmission-based precautions, people are going to have to decide, when am I putting a mask on or not, if they choose not to follow the recommendation. So I'm going to have to remember that in this case, the patient has to wear a mask, the visitor has to wear a mask, I have to wear a mask. So that's going to take a lot of reorientation and support to our staff to make sure that's clear. And if we do all that, the risk is really low. If you look at transmission rates right now, that is really any different than March of 2019 for infectious diseases, right? Like if it was flu or
You envision the mask that's required in these particular times transitioning to something like KVH strongly recommends anyone entering this facility mask. KVH requires that anyone symptomatic wear a mask in this facility. KVH requires that anyone who's been exposed to COVID would wear a mask. So that's kind of what we envision at this point. I will say people are not only ready, they've heard, I don't have to wear a mask after April 3rd. So it has been our position. We're not going to become an organization that looks the other way. We need to know what the expectation is, who has to mask. We've really held the line on this, but people are very argumentative about this. Our employees and people outside, they are. If we tell them they have to wear a mask for 4 more weeks, just while we get used to it in April, I think we're going to have a rebellion on our hands. So.
And it's going to be difficult regardless, because as we go to transmission based, I don't think our patients are used to that either. So if the sign says it's recommended, they may totally disregard this other piece that say it's required and push back on us when we say, hey, you need to put a mask on. No, I don't, it's not required anymore. I'm sure that is going to happen. We will probably have instances too where a patient asks a staff person to wear a mask for their comfort and that's what they, that makes them feel safer. And we're gonna have to help our employees to be supportive of that, right? And we're gonna have to make sure that our folks that do follow the recommendation and mask all the time are not treated poorly by others, and vice versa. People who choose not to follow the recommendation, we can't have our staff retaliating against each other. And so it's just about continually showing our values, and it's going to be a little tricky. It's going to be a little uncomfortable. There are people that are not going to be comfortable with it.
And stay tuned if LMI comes out. and says,
Yeah.
Never mind, we've got it before now.
Or DOH, or CDC, or OSHA.
Real interpretation.
Yeah.
Okay, well, I mean, that seems.
It's clear, but if we say this and we don't change our signs on our doors on Monday, and we've got employees in the buildings not wearing masks, and a patient just walked past a sign that says masks are still required in this building, that's gonna be really disconcerting to our patients and our staff. So it's.
So you telling Ron to get on it?
No, that's the first he's hearing of it. Yeah, no, we're gonna have to figure that out. So that's part of the challenge is, like I said, we just talked to LNI today, where they're saying, oh yeah, these two conflicting messages that we really mean this and we're gonna change it soon. So we're doing the best we can, and people don't wanna wait, but how do we do that in a way that is safe? So
You guys have any questions, Mandy? I thought that was really clear. Thank you, Mandy. Anything else from you?
Well, the one thing I would say that I've really been thinking about as we've had these discussions is how will I choose my behavior? When I think about my role and when I look at these recommendations, they're recommended in all of healthcare for everyone. That's what DOH says. So when I think about, well, what am I going to do April 3rd? I'm probably going to wear a mask everywhere, which is annoying. I don't want to, but I think that's the right thing to do. And so I think that's something you might think about is what will you do on April 3rd or encourage employees to do. But ultimately, this is our recommendation and they get to decide whether they follow the recommendation, but we have to do what's required. And so we will, but that's the last thing I'd say is it's hard to think about that. And, what I might choose as an individual outside of work and what I choose to do at work based on my role.
Great.
That's all I have.
Thank you, Mandy. Appreciate it. Next up, we have CEO report, Shirley Peterson.
I do have some comments I would like to add, and I'm happy to answer questions. I mentioned briefly in my report progress that they're making in the clinics, and I just want to spend a few more moments on that. And Mandy stole some of my thunder. They do have great new quality metrics that they're following, using, and daily reporting. And this is something we've looked for, we've struggled for, and we've never, until now, really had timely data that we can use with the providers and the clinics. Our integrated behavioral health programs, both in Cleveland, which has been up 3 years now, I think, is at capacity. They translated it to family medicine Ellensburg about a year ago. Holly, our social worker there, I think is supposed to have 80 clients. She has 90. So we are having an integrated behavioral health summit to sort of look where we're at with the program, having support that. But I know there are asks coming about how that can continue to grow in the clinic. So we're going to look at that. Part of that is for your June 3rd meeting. And they have a great new onboarding process for new providers in the clinics where it really is sort of a 360 onboarding. To Leanne's point earlier, there's a PCA built in to make sure that our providers, and I think Family Medicine Ellensburg has 3 new providers so far this year. So that has been really, really helpful, standardizing the way we introduce providers to the community and our processes to our
So far.
Was that
emphasis on so far.
so far? They also, I sent an email out to the clinic council, which are our clinic leads. We have a number of projects that we started some time ago, like improving the phone communication for our clinics, pharmacy rebuilds, and you'll hear more hopefully from Rhonda about how that program's coming, reducing turnover and then making our PSRs and NAs feel more competent. Those initiatives are only a year old and they have just borne incredible fruit. And the MA apprenticeship, I think you have 15, we just started, we're gonna be starting one more in April. So all of these things that are underway, Dr. Gibbs is allowing us in talking with the clinic council to get that next set of processes that our physicians want in order to improve their practices. So just really exciting stuff going on in our clinics and feels like a lot of momentum. The other thing I want to mention, and I say this way too often, but in case you haven't experienced it, we don't stop and celebrate enough. Ron and Jim managed the cafeteria remodel through a pandemic. That space is so improved, and it's not just the flow that has improved down there. It has created meeting places for people. There's also, areas where people can sit by themselves for quiet time. We're finding that space. I think it is an exceptional result. And, again, we said, thanks, Ron, next project. What have you done for me? But it has turned the project is really good. So I wanted to call that out. The other thing, and I had a chance to take Terry down here the other day. 2 years ago, the break room for our med surg staff and CCU staff was, I think it was an old supply closet. It was interior, no windows, and it was right by the nurse's station. So they weren't getting much in the way of breaks. We took the opportunity of moving the hospitalists around to take one of the two front rooms. We used to have a chapel and a waiting room, and we kind of compete and combine those things. So we have a new staff room there that has windows onto the courtyard. Ron had a door cut into the staff room so that our staff can go out into the healing garden there. And we're going to enclose that a little bit so that these folks really can go have a break, go outside, soak up some vitamin D. So if you get a chance to go down there and have a look at it, I think moving from a dark little cave in the center to a place where you truly can go maybe breathe a little bit and get away from the workload for a while has been a wonderful addition. So just an opportunity to really celebrate some of the stuff that was done in the dark of the night during the pandemic. So
Yeah, the new break room is really wonderful. I appreciate Julie taking me down and showing it to me, but it really is going to give the staff a nice place to sit and have a break and able to, especially in the summertime or even in the wintertime, be able to check out the outside.
the only other things I'll mention tomorrow with regard to fragility of rural OB, we do have the summit. It's a 3-hour summit with the Department of Health, the Rural Health Collaborative, the Healthcare Authority, the tribes, and some of the rural hospitals. People have an opportunity to talk to the policymakers at DOH and the Office of Rural Health, which is a HRSA-funded office, about what the challenges are. I get the first 5 minutes to sort of talk about, the alarm we at KVH reacted to when Toppenish closed their program and how we really started that ball rolling of talking to other rural hospitals. And so many rural hospitals were really one nurse away, one provider away from losing that service altogether. We've got some heavy hitters at the table who truly are policy, and we are approaching this from an equity perspective. We believe that the populations in rural communities represent communities and distinct populations that need the same attention to equity and outcomes that we're affording to other communities. So I'm at the top of the agenda, and then I'm going to get out because everybody else there's a clinic or a clinician. And then Monday, we have a number of people attending the Rural Health Conference in Spokane. And I I will be participating in a panel about retention and establishing a culture that promotes. That's it. I'm happy to answer the question.
Any questions for Julie? You're representing Amanda. I don't know what possible reason.
I know, I got to meet Rosalie today, and everybody else. She was here for her fourth trimester appointment, which, in case I haven't said it lately, that fourth trimester program that we support with our nursing department is absolutely fabulous.
Any questions for Julie? Thanks, Julie. Next up, we have operations. Vicki, am I right? And have I heard correctly that this is going to be your last time for this?
You did. I was gonna announce that, but I'm glad you did that way. I don't have to say it out loud.
Well, can I say that your retirement party is going to be April 14th? Right here, 11 to 12:30.
April, you could be.
April 4th.
April 4th.
April 4th. All by yourself.
April
I'll be
4th.
in Israel on the 14th.
April 4th, yeah, that's right. April 4th, yes.
It'll be the 4-year-old, not a teenager, 14.
April 4th. All right, so yeah,
Yeah.
hopefully you guys all got that. Thank you for that.
Yeah, so my last report is on 23. We've been very, very busy in my department. And just a couple of weeks ago, we got an interim director in the ER, which is giving Dee an opportunity to hand off the ED and for me to encourage her to let go of the ER. It's hard for us to let go of our work. We're so proud of it, but that's going underway as long as, and it seems like every department mentions the construction, so it doesn't impact our people. And they're pretty resilient and flexible in dealing with that. Stacy highlighted the fourth trimester. That's, like Julie said, that's just been a wonderful program for them. And then our clinical educators have been very busy. We are having our first meeting with our union reps next week. So that'll be a new staff development involving, each department has an RN representative there to help us collaborate a little bit better. Any questions for me?
Someone's got to ask a question.
I just want to take this opportunity to thank you all. It's been, wow. It's been a wonderful part of my career being here for the last 28 years in various roles. I've been given a lot of opportunity I never expected, but I'm very thankful for. I'm proud of this hospital. I'm proud of the nurses and the care that we give here. So very honored. I do believe. So thank you all.
Well, Vicki, I know that the whole board really appreciates all the work you've done and your leadership, and you will be greatly missed.
I'll be around in little pieces.
Before you get there, I'd like to introduce you to our new house supervisor.
But I'll be here a little, just not as much, which is, I'm looking forward to that.
Yeah.
Yeah.
Okay. Thank you very much.
Thank you.
Next up then, Rhonda.
I'm making all teary-eyed and makes me speak. That's not fair. I have actually quite a bit to add to my report. Julie mentioned about our pharmacy technician apprenticeship program. We ended up with 30 applicants into that program, which is really exciting. And we have narrowed it down to 2 that we would like to make offers to. One is an internal candidate and one external. So pretty excited to get that program going. We will start training them clinically to be, pharmacy technicians, and then they will be helping with the medication refills in the clinics. We're going to house them over at the MAC Annex and working with Ron to kind of try to find some soundproofing to help with that work that they'll be doing with patients on the phone and med refills. So it's a little soundproofed, just a little bit. I did hear that the Clayella-Roslyn School District had a presentation at their last board meeting from CHCW, and they are looking at potentially partnering for a school-based medical and dental clinic. So I'm going to meet with Mary their school nurse next week and just kind of see exactly what they're needing and if there's anything that KVH should provide or they wanted us to provide. Of course, we don't do dental, and it's very hard to find dental, but I think the push came because none of the dentists in the Clayelum area are accepting Medicaid for the children. So hopefully I'll learn more about that. I found out today that 47 Degrees North did submit their application to the city of Clayelum. So that application you can look at on the website. It's pretty extensive, but it's everything that we expected it to be. There was nothing anticipated in the application. And I did include the SEIS supplemental environmental impact statement addendum that they had created for their application packet. And I forgot to mention that in my report. But it did talk about Hospital District 1 and Hospital District 2 and the impacts that may happen, which they, of course, are minimizing, that there will be much of an impact to either hospital district. And really stating in this document that they feel like if there is any shortfalls because of the growth and the rapid growth, that we could make it up through fees to patients, which is not necessarily true, as we all know, but they don't. So I felt like it's important for you to see that. They do also talk about mitigation with the various public service agencies, including us. And I think for the hospital districts, they're pretty much saying it's a wait and see. And if you have a major impact, then it's something that we need to bring to the table and say we need mitigation for. But nothing that they were offering within this document.
Hospital District 1 is assessments on page 46, and essentially they say we want impact.
Let's see. We did get notification from HRSA that they have accepted our 340B corrective action plan. So I was really happy to receive that. We do have to report back to them by September to make sure that we have had full contact with all of the manufacturers that were impacted. And we are already receiving emails or letters from the manufacturers saying that they are accepting our corrective action on what we have done when we had these medications on an inpatient, and you can't use them on inpatients, it has to be for observation patients. So I think there ended up being 7 or 8 manufacturers impacted. We just reversed that on the accumulator, and so there was really no money exchanged. And I think overall, out of those 8 manufacturers, it was less than $200. Can you wait? That's all I have. Do you have any questions for me?
Questions for others?
We now have a pharmacy tech apprenticeship program in the CNA apprenticeship program that will help with our patient service.
Yeah, that's, I mean, it's wonderful to have all that. I mean, that letting people advance inside the organization. Thank you very much, Brooke. Next up, we have Stacy O'Leary.
Yes, my report is on page 69 through 72. Only additional comment is we have our new clinic director of nursing. She started this week, Jamie Georgeson. She was one of our traveling nurses who lived in Clayelum, so we're really excited we were able to recruit her and get her on board with KVH. Rapid access. Can you just say that again? We talked about it. Rapid access. As you can see, I did change the date to May 1st, but the good news is we do have 2 providers who signed contracts, and we have 2 MAs, 1 external, 1 internal, who will be filling that position.
Why did they get pushed? Just out of curiosity.
It's more credentialing issues, plus they had to give notice. Both of them are working in other locations, so we had to work around their notice they had to give.
That's exciting.
Any questions?
Any questions for Stacy? Thank you very much.
Thank you.
All right, next up, we have the medical staff. Dr. Avi's not here today, so are you filling in for it? You want to tell the board, I know that as you're sort of second in charge of MDC, so You want to introduce yourself, please, to the members of the board?
Hello, everyone on the board and members of the committee. I am Andy Thomas. I'm a family physician from Cleon, and I'm the vice chief of staff filling in for Dr. Hoppy in her absence. On March 15th, the MEC met to consider the applications of 7 initial appointees and 5 reappointees. And after a lively discussion about future standards for hospitalist scope of practice, we all agreed that we felt it was appropriate to recommend the applicant before you be recommended to the board for their appropriate appointments.
Thank you very much.
Happy to answer any questions if there are any.
Are there any questions for Dr.? No. Everybody's had a chance, I know, to review these electronically. The system's still working very well. So do I have a motion to approve and to credential these providers as indicated?
Move to approve.
Second. Okay, a motion by Erica, second by Terry. Any further discussion? All those in favor, please say aye.
Aye.
Thank you very much, Dr. Thomas. Next up, Dr. Martin. Yeah.
You have my report, on page 74. One thing that's development since I wrote this is working with our recruiting consultants. We were made aware of a kind of a cyclic change in the available position market. For a number of years, the number of family physicians who underwent fellowship training and became trained in surgical obstetrics has been falling. For whatever reason, in the current market, there are more family physician OB providers available than there are OBGYNs. And so we pivoted our recruiting and are looking at what that looks like from staffing model, how they interdigitate with their OBGYN colleagues. But we've made 2 offers to family physicians with surgical obstetric training and 1 to obstetrician disabilities by the closure of the department. We have 3 more interviews scheduled. In the meantime, at least one of the locums providers that you previously approved has been a great fit for us, and we're hoping to convince her to come to the dry side of the state. But one of the reasons for the brevity of my report is that that recruiting work has essentially been my work. We are stabilizing emergency staffing. And I'll have additional comments in the section.
Any questions for Dr. Martin?
You see recruiting becoming easier going forward? Is the worst behind us, or we're just going to stay in this?
One of the things that's happening nationally, and we're feeling it to some extent locally, but a lot of physicians, a lot of APCs, a lot of nurses, were kind of hanging on by their fingernails to get through the pandemic. And psychologically, a lot of them, there was a piece of the New Yorker earlier this week or last week that focused on nursing, but just the number of folks that said, I don't want to do this anymore. And we're seeing that in medicine. I saw that a huge number of, we had match day where graduating medical students learned what they're going to do their residency training. Emergency medicine had one of the worst match rates it's had in decades. And that's normally a very desirable specialty. You've got control of your schedule. When you're not at work, you're not at work. And you're well compensated for it. And there was something on the order of 500 residency slots that went unfilled.
So graduating students were not applying for these open positions. So.
Yeah, they just said, I don't want to do emergency medicine. I don't want to be where people can call on me. I haven't seen the numbers for other specialties. my understanding is our local residency is quite well in the match. I would be curious to see what changes there were in specialties like radiology on one hand versus anesthesia and ophthalmology, which those two specialties, along with emergency medicine, were the early in the pandemic were the highest fatality rates. And it would, we're seeing folks graduate that about the time they were deciding on their specialty, those numbers were coming out. And I think we're seeing the effect of that. The other trend that I'm aware of is that nationally medical school enrollment is down. Folks that are smart enough to practice medicine are figuring out there's other ways to make a living.
Are we seeing very many physicians being brought into the United States from other countries? They've gone to medical school in other countries, and then they're being immigrated over here.
So there are two visa categories, J1 and H1B, for foreign medical graduates to come to this country and practice. We are not alone in accessing that labor pool. Interestingly, we've had a fair number of applicants from Canada, which, the last time we hired a Canadian citizen, it was Dr. Feng, and he didn't unpack his bags of boxes for the first few years he was here, and that was nearly 30 years ago. But we aren't seeing that much interest in that market. We thought that was going to be a vein we could mine, and that hasn't been the case.
So we haven't really seen whether there's anything to mine out there, because there aren't people from other countries wanting to immigrate to the United States and get those visas.
Yeah, again, two of the recruiting firms we work with are very proud of their success with foreign medical graduates. And we haven't seen an FMG candidate for probably 2 months. My sense is that they just, for whatever reason, aren't trying to immigrate here.
So it's not as much of being able to hire a provider from another country. It's that they're just not right now interested in coming to this country.
Yeah, we aren't getting the candidates presented to us. The other thing that we saw in particular with the FMGs we interviewed was, for the most part, they were looking to be close to family in Seattle and Vancouver. And we were a spot on the map. And when we weren't bringing candidates here to interview, we were just a spot on the map. And they figured out that there were other spots on the map that were closer to the time.
So have the people that try to bring people, providers from other countries, have they mentioned the reasons why they're not coming over here? Because I would think that their financial resources would be greater here than they would possibly be in other countries. Have they said why providers in other countries don't want to immigrate?
I think in no small part it's because the specialties that we were really focusing on was ambulatory internal medicine. And that is a specialty that is disappearing. Most internal medicine graduates are either going on to subspecialize or they're becoming hospitalists. And I think the days of the primary care internists are probably numbered. And we've had conversations about whether we need to look at not so much recruiting internal medicine as adult medicine, and providers who don't want to necessarily see kids who are more interested in geriatrics. But that's something that will probably be mentioned at the strategic planning update.
Okay, thank you.
Any other questions for Dr. Mark? Thank you, Dr. Mark. Before we move on to Scott's report, I think we have to add, you have 3 capital expenditure requests, right? We should add that to the agenda.
Yes.
So, sorry, I should have noticed that earlier. But just before we get there, do we have a motion to,
I'll move to amend the agenda, include 3 capital expenditure.
second, from anybody? Second from Mayor. All right, so we'll add those, please, let's have a vote, just make it official for the amended agenda with the 3 expenditure requests added. Please say aye.
I,
All right. Sorry for the delay there, Scott. Okay, Scott, it's all yours.
Thank you. The finance report starts on page 76, and but I'll start with this, the stats on page. You can see that I actually haven't made or bring actually a very good financial report. Had some good reports the last couple of months, so this is much better report to bring to. As far as stats, you can see we have been quite busy. Admissions were a little bit off, but patient days were over budget, leading to higher length of stay, which is going to be a concern for us going forward. As a critical access hospital, under the we need to be at an average length of stay of 4 days, and we have been at 4.9. And under the health emergency, this is not a problem for us, but when that health emergency comes off, that is a target that we need to be at. And it's not just a monthly basis, it's 4-year average for the year. So there can be some differences, but it's something to be, that we need to watch.
How do you bring that down?
Were we talking about splitting things out? Because some of those, it's not because we can't discharge people. Is that accurate?
That is
So
correct.
we're done with their care, but they're occupied in bed and still counting. I think we're going to look for clarification from DOH or somebody to say, can we legitimately split these apart since?
Yeah, like currently we've got 3 in-house that are pending.
So they're
authorization
ready to be
go.
discharged, but
Their
they're
medical
still.
care is ended, but we have no place to send them.
we're gonna need to be really disciplined about transitioning those patients to swing bed. That takes them out of the mix, correct?
It does.
So, and it hasn't created any harm so far, but we need to start moving those patients to swing beds out.
what does it take to move them to swim bed status?
Well, they have to have a scalable need. Some of them do, most of them don't. The people that do have a scalable need, the nursing homes are quick to take them because they get monies for their therapies, right? They get
They get
PTOT. and that-
enhanced reimbursement for the first 100
It's
days.
the patient that's been cared for at home by their family can't do it any longer, their needs are greater. They're not gonna medically get back to a place where they're independent, so they need to go to long-term care. Those are the patients that are more difficult.
The 2 things to do to address this that I've heard, one is to move to swing beds, the other one is if they're ready to be discharged, that nobody to put them, we sort of separate those out.
We need to find out whether CMS, we
Right.
have to make allowance for this. This is huge.
It can't just be us.
It's not unique to KVH.
No.
This is a state.
Is this when they enter border status then?
We-
Or is that different?
Right. When they're medically ready for discharge, they're considered aborted for however day that is. If it's 1 or 2 days, sometimes it's 2 or 3 months. The longest we had was 74 days. It was just here over Christmas.
Do the charges stop at that point? Or are they not?
No.
So they're still potentially paying, and that's creating a different type of problem.
Yeah, we work with the insurance companies too, because a lot of these are Medicare or DSHS plans. So they have caseworkers, we work with them as well, but they just have as much difficulty as we do as finding places.
It's actively being worked. It's a problem for us and other organizations, and it's not like we're just not trying to, there's an awful lot of effort going on.
If we didn't get it corrected and we don't get a waiver, what happens? that number?
It would, I don't know the answer to that, and we'll continue to operate, you know, we need to care for patients, there may be a financial penalty of some sort, I'm not sure exactly what happens with that.
Okay, thank you.
But you can see, anyway, from that, that's just something that you need to, you and we need to be cognizant of and plan for. Case mix on line 8 was in excess of 1.09 in excess of budget, and year to date is running ahead of where we were last year. Surgery volumes and surgery minutes and cases are very, very busy for the hospital. And in a primary driver of some of the positive revenue variances that we've had. And I guess I just have to say compliments to Dr. Martin, particularly, and those that have recruited for ER. You know, we've had challenges with provider coverage, but it is reflected in our stats who were well in excess of budget. So it's Vicky and Dee Dee and folks that are busting their tails downstairs and providers that have really stepped up. It's really quite remarkable to be able to have report, you know, a very high ER number with the challenges that we've had down there. But we're still continuing to serve the community well there. Radiology exams are driving a source of revenue. It's kind of related to some of the surgery colonies have. Most of the patients that go to surgery are also getting scans, and so those are, again, positive revenue variances. The clinics down on line 28 and over budget for the month and over budget year to date, and you look at the 13% over the prior year. So just these stats that I am going over are lead to the positive revenue variances that we'll talk about over on page 81. And we were over budget on $1.6 million. It's $19.7 million on a 28-day month. Year to date, we're over budget by almost $3 million. The other operating revenue is trending closer to what we had budgeted. I'm optimistic that Nassar has applied for the 340B ESP program. So we're thinking that I believe that we'll be able to capture some additional 340B contract revenue.
Going forward or going back?
Going forward. It will probably, it's about, let's see, probably 45 days or so out. So that should help us. On the expenses, the budget on salaries, the temporary labor up over budget, but down from the rate that we had been running at. And you know, as Stacey just alluded to, there's our new nurse manager for the clinics who was a former contract nurse. And that is, I think Rhonda has only one contract person in home health hospice now. And so it's across the board. And Vicky, also, I know you're almost, and you still have some in ER. Still have two.
Two in ER, but there's 4 in surgery. We just cannot find a surgical nurse. So,
but it's come down dramatically. It will continue to trend down. So that's very positive. On the professional fees, the negative variance is related to some of the local positions that we've had. So overall, a negative expense variance of $612,000, but it tracks with the positive revenue variance that we had. So we were able to post an operating income of $517,000 for February. And year to date, we're positive at $123,000. We had some unrealized losses on the hospital's investments. So we had that negative non-operating variances related to unrealized losses, but we did earn over $100,000 on interest on the funds that the hospital has set aside in the LGIP and in the treasury bond. investments that we have. So net income of $524,000 for the month, and we're trending in pretty good directions for everything else. We had a pretty strong cash month for February, just over 10 million in collections, and some of the AR had creeped up on us in January and February. It flattened out in February. It looks like we're having a really strong collection month in March, and I anticipate those days and accounts receivable coming down. But good finances to report for February and year-to-date. Questions by anyone?
Any questions?
I want to thank the directors and operating staff again. Scott and Jim completed a report on temporary labor that they're giving people every month. People are there spending those dollars, but it just really embraced the idea that we need to focus on our internal staff. And it's taken us about 3 months to make an amazing change.
One additional item I would just say is that Julie and I were on a phone call earlier this week with our state auditor, and we had a bit of a finding, as John is aware of, related to the procurement of architectural and engineering services. And when for District 1, and when we were on the phone call with an exit conference regarding District 2, the state auditor had talked to the Attorney General's office, and they said, these regulations related to procurement of architecture and engineering fees are vague and gray and hard to interpret. So they are going to reissue the report for District 1 and take that finding off. And so that was, so we John was not the only one that had pushed and tried to understand something that was very difficult to understand. We've had similar conversations, and Julie, Jason, and myself.
We try very hard to follow the rules, but when the rules have a certain vagueness, at some point you have to interpret them and make decisions, and we thought we made fair and legitimate decisions. So it's great to see that after they reflected upon it, they came back and said, we agree.
So that was very encouraged with that. And then we have some capital to talk about later. There's a lot of questions.
Any questions before we get to the capital expenditure request? Okay. First up,
The first item is for some surgery equipment. It's Souter orthopedic drills and saws, and for $248,000. Our Striker drills and saws are at life. Amy's had this on in process, had on this list to purchase these for a number of years, and she's been kind of working, just using the others. We're still functioning fine. They're starting to not function well now, and so these are proven. It's a different brand that we have used in the past. Dr. Longo has used it down in Yakima. Yakima has been converted to a lot of Souter ortho equipment. So this is replacement orthopedic drills and saws for our Striker drills and saws that are at end of life. So this is a budgeted capital request.
And did you also mention that the expendables that this uses are either cheaper or last longer?
They are less expensive and they seem to last longer.
Dr. Longo will be speaking to three totals of data.
I think we really need to approve this too, because after the winter time, since we're an agriculture area, historically, we've had a lot more orthopedic issues during the spring, summer, and fall. And so having the correct equipment to here, so that way the orthopedic surgeons can do the best they can, I think that would be really good to approve this.
We'll say they have trialed this in surgery already. This equipment. So this is the doctors have used it and
Right.
And what's the turnaround time once this is approved?
I think it will be fairly soon. We'll place the order tomorrow.
Yeah.
Any questions before we entertain a motion? John, would you like to make a motion?
I'm happy to make a motion to approve capital expenditure for the new DeSauter medical orthopedic equipment.
Second, from anyone?
Second?
Okay, Erica seconds. All those in favor, please say aye.
Aye.
Thank you. Next one.
Thank you very much. On the Mind Ray ultrasound for the emergency department, I neglected to, I didn't have the cost of an interface, that cerner interface that will be part of this. We have typically expensed the interface expenses, but when I bring things to capital, I usually bring the total amount. And the 71,630 did not include an interface of the 12,800 that I was not aware of. So this is a Mind Ray ultrasound equipment that will be used in the emergency department. And you can maybe comment about the state of our existing ultrasound.
It's been here longer than I have, which is a lot of years. It's currently been out requiring repair, having a hard time getting parts for it. It's pretty much at the end of the life. And it is not able to capture images, which when we do procedures, if we capture that image, that helps with generate revenue. So we've left some money, that we've not been able to bill for when we're doing specialized procedures, both nurses and physicians and providers.
Is this the same type of? When we did the Gemba down there, there was a.
Yeah, we were
we
borrowing
took it in
Anesthesia's
To do
ultrasound machine, because our machine.
For IV started, okay.
Yes,
So this would facilitate that sort of
yes,
procedure.
the ultrasound guided IVs for difficult IV starts, where we can use our own nursing staff instead of calling in anesthesia.
And it's my understanding, the new system can be used one-handed in a sense to capture or do what they need to do so that.
Scott, did you say that this amount on here includes that extra for the interface?
It does not.
Does not,
Does
so.
not.
And to be fair to Scott, he emailed Bob and myself as soon as he became aware of that. And so we've known for a day or so. And
We need to.
That's fine, so we need to amend that, I guess.
do you want it amended on this or you just an advisory
It was
comment?
more of an advisor, but we can amend it to.
Well, you're not gonna capitalize it.
I'm not gonna capitalize
Yeah,
it.
because those are expense now, so, but we
He
typically.
usually just advises and he felt that he didn't have that information when this was submitted.
All
But
right,
So there won't be a problem moving forward
No.
if we don't amend it.
okay. Do I have a motion to approve this expenditure request?
I will move.
I will second.
Okay, all right, clear. John, any last words before we vote on?
Nope.
Okay, all those in favor, please say aye.
Aye.
Thank you very much. And then the last item is a large capital request for a chemistry and an immunoassay analyzer for our laboratory department. And this is we currently have a Siemens Vista analyzer, and it is at end of life. So end of life. Also, it is frequently down when the lab project was planned and redesigned. It was generally speaking, not specifically, but it was generally designed around a Siemens type of analyzer, but we didn't know the specifics of it. So the Beckman Coulter it's 32 feet long. It is very, very big. And but the open concept that we build our lab is allows us to move this large piece of equipment into the lab. And so there is some, in addition to the cost of the analyzer, which was about $547,000, there is some construction work of totally $217,000 that will need to be done. And then there is also $109,000 of an existing Roche machine that we have that we lease, that we will buy out that lease. And so This is, it's an expensive transaction, but this is a piece of equipment that is proven. It's being used by many of the hospitals in the state. Supported by from a tech perspective and a technology perspective. And it will serve the hospital well into the future.
Did I hear you correctly? 32 feet long. Is it supported by vacuum tubes or what? It's so large.
I think it does some of the specimen handling and processing, and it sends it down like a little track. And there's actually two immunoassay internalizers in one.
We get redundancy. There's total redundancy with this.
Nice. Yeah, what it is here.
I went down and paced it out.
How large is the current one?
It's about 12.
Smaller, it's not as long as these two tables. The current system is much
smaller.
The new system will go like from here to that wall. And
It takes up the entire back wall.
Several pieces that
Yes.
some assembly requires. Okay.
So anyway, this is, I kind of wrote the story of what happened with Siemens in the narrative, and the CI 1900 is not FDA approved, and it's been pending for years. So we do need a new lab analyzer. This is the best device that will fit our needs for now and well into the future. So. Any additional
So they invited me down to the lab to talk about this because obviously it's a big expense. And Rhonda and Scott and Katie took me down there and we spent quite a bit of time discussing the current machine, its inadequacies, what the new machine will solve. And I didn't catch the name of the lab technician that spent some time with me too. And she was wonderful in giving me kind of a firsthand sense of what it feels like on a Friday night when our current machine goes down and ER needs lab results to help somebody. And they've got to ship it off to Yakima or something, 15 minutes turns into 5 hours and stuff like that. So she viscerally had kind of that, it is so stressful, sort of thing. And so it was great to spend some time and just hear firsthand from the people that use it. So it's a big expense, but we knew it was happening. So I know we pulled some money out of the lab budget and set it aside that we didn't spend at that time, which we'll now use to do a little bit of modification to make this new unit fit. It sounds like you guys did a lot of research on what our options were. This is the best one. So, and I think, Scott, you also negotiated some discounts for the new machine to offset the cost of like buying out that lease and so forth. So it feels like a lot of thought went into this. So it is a big number, but we run a hospital, we have to have lab. And I believe this is approximately an 8-year lifespan, maybe well beyond that.
perhaps even longer.
So, and with our new strategy of buying rather than leasing, it hurts a little bit more upfront, but long-term, I think it pays big dividends. So I was reluctant going in, but after long discussions, I'm very supportive of it. So
Makes sense to me.
consider that a motion if you want, or we can have more discussion.
Any further discussion? Okay, then we have a motion.
So I'll move to approve the capital expenditure for the new Beckman.
Second, good motion.
Okay, Erica seconds. All those in favor, please say aye.
Aye. And can I just say, Randy Manager, Katie, I absolutely put this in the cases. I was really helped by the idea of taking care of Randy. Katie did an absolutely fabulous job of shooting down every single thing that I brought.
I'll second that.
Yeah.
It seems something of this size and caliber needs a name. Is somebody going to name it?
So they usually name their equipment. So, yes, so I'm sure they'll come up with reports to follow.
Yes. I'd love to hear what they end up naming it.
Okay, thank you for that. Then we have a surplus equipment.
And you'll see that we're going to surplus this in the analyzer on this to go away.
Okay. Any questions about the surplus?
Remind me, was something about the scrap, is that demolished and crushed down into nothing, or can it be used in other?
If it can't be sold, it will be sold for, if there's any value to it, we can find someone that has a useful, it will be sold. We do look for, it doesn't just go on that.
It will not be parked in the basement. Right, Ron?
Would that still be listed as scrap though, if it was?
Yeah.
Or donated to a program or something?
Yeah.
Okay.
We were having moving parts. It's hard to imagine that.
Anybody else we have used for it? Gotcha.
Okay,
But yes.
any other questions or conversation about this? If not, then we have a motion to approve the resolution 23-1 surplus property. Right here.
I'll second.
The second, Terry. All those in favor, please say aye.
Aye.
All right.
Thank you very much. And Mitchell has his report of some of the grants that he's working on. I usually, when we get the check, I kind of out it a little bit more, but anyway, he's actively working on some grants for KCHN and the hospital. And, so,
Great.
thank you.
Thank you. Anything else, Scott?
I don't have anything unless you have.
Any questions for Scott before we move on?
Thank you.
Thank you, Scott. All right, education and board reports, HA annual meeting coming up. I'm going to that. Then we have a leadership summit in July, which will be in Seattle. Do you have any thoughts about that one?
That was one that was in San Diego last year and organized several of our newer youth, I think John and Matt.
Yeah, it was there.
It was a great opportunity for the new leaders to go and get this world-class introduction to leadership and leadership specifically in healthcare. So again, this year it's in Seattle.
Okay.
I hope some of them say, again, I really appreciate it going to the board to get that opportunity to kind of.
So this is something that if we were available, you would encourage that board. So please check that on your calendar so that we can get the early bird rate. Whatever that is. Okay, old business, we're going to talk briefly about the draft agenda for the retreat. You all have a draft agenda with you, hopefully. Justin, did you have questions or want to talk about this or?
I don't have any questions about it. Julie and I spent some time today, and then we also had a meeting during SLT on Tuesday about this. Just organize it all. We're going to start at 9 and should only go till 3. There's going to be a breakfast and lunch provided, but beyond that, if you guys have anything specific you want to add to this, please let me know. This is what we came up with in the last few days.
So between now and June 3rd, anticipate that you'll be called by, as the board sponsor for learning strategies. We want to update that, and you'll notice that it's in the follow of strategies. So last time we met at Yakima Canyon, we walked you through sort of the flow of revenue, how referral revenue flows through the organization. We'll do that again. So we, in addition to SLP and the board, we've invited Jason, Tricia, and Scott, and Justin. Tricia's going to go through. I'm really excited about this. I just sort of point and yell, do an evaluation of this with her all the time. She's evaluated infusion programs, updates cardiac to a vascular program. She will walk you through those and tell you, where we're at in the go, no go in terms of presenting some of those to the board. So that should be really helpful. Then we'll move on to partnerships and collaboration. We're working on the partnerships on getting the patient safety culture and employee engagement survey out. If you will recall, 3 or 4 back in the pre-pandemic days, we had the board really encourage employees to help participate in the employee engagement survey. I think we got 80%, or I mean, unheard of. So we're gonna tap you guys again to really help us with the patient safety culture survey and send it out to the employees. We'll do a SWOT analysis. Mandy's gonna lead us through our markets really changing, you know, and we do want to talk about the entirety of Kittitas County. So we'll be talking about some of the issues that Rhonda brings to us about 47 degrees north and growth in Upper County. And then we will end with some questions that we have, financial sustainability and growth. And so following strategy.
Sounds good. Any feedback on this draft agenda?
Last year, I thought one topic we had was related to employees, things we were trying to do is that included in your employee engagement?
Yes, it is. And Amanda Scott will be making a cameo appearance in this. She won't be back to work, but she's going to come and participate.
Any other feedback?
6 hours, it's gonna go so fast.
Yeah, it is fast. You have.
Breakfast is better real quick, you only get 15 minutes.
No more practice.
All right. Thank you for putting this together. Before we move to executive session, one more reminder, April 4th, semi-retirement party. I say you're trying to get a couple of different parties, I think, out of this staggered retirement. This is okay. But April 4th, 11 o'clock, right here.
This very space.
This very space.
Yeah.
Okay, Julie, how long do you think we need for executive session? So, right now it's 7:37. Let's take that.
7:26 right now.
7:26.
Just turning
7:27. 7:27, and then so let's say till 7:35. We'll take a break, and then let's go till 8:05 for executive session. All right. Thank you.
Thank you, everyone.
Yeah, Katie, well done.
Yeah.
And I told
She said she's gonna name it